Hello. In this section, I will talk about anesthetic management of a patient with severe brain injury. Now, patient with brain injury may have a lot of other associated grievous injury in them, like they may have associated internal organ injury or lung injury or associated spinal cord injury. So, we need a proper multidisciplinary approach to manage these patients. As an anesthesiologist, where are our roles? We have roles at multiple places, like we are required for managing an initial stabilization of these patients in emergency department. Then we are required for providing the sedation supports when imaging is required in these patients. Then we are also required for anesthesia in case of any intracranial procedures are being done, or if some associated injury is being first managed, we are required to give anesthesia for that. Then also for post-op management of these patients in ICU or post-anesthesia care unit, our services are required. So we have a role at multiple places, and that's why we need to know about the perturbation of the physiology which happens in these patients to give a good outcome. So as an anesthesiologist, where are our roles? So our roles are at multiple places. Number one, we have a role in resuscitation and stabilization. Stabilization in emergency department. Then our role is for sedation, for providing sedation, for diagnostic imaging. Then our role is for providing the anesthesia for craniotomy or decompressive craniectomy. So for craniotomy and craniectomy, the anesthesia support. Then we are also required for extracranial surgery in these brain injury patient, and of course for ICU management. Now, when we are putting these patients for surgery and anesthesia, then there's always a possibility of secondary insults happening in them, further deteriorating their condition. So there are some important measures which has been recommended by the Brain Foundation, Brain Foundation Society to manage these patients. There are some, let's say, recommendations for maintaining the arterial pressure. There are some recommendations regarding the level of monitoring required, interventions required, and everything we will discuss in this section. So what are important concerns that we have to we have in preoperative care of the pre-anesthetic evaluation of these patients? So even if we are taking these patients for emergency surgery, very quick pre-op evaluation has to be done. Number of times patient may not be oriented or conscious to give us a good history. Number of times patient may be brought not by relatives but by some strangers. So you may not get a proper history, but whenever possible, take a proper history regarding his comorbidities, regarding his allergy, regarding his medications which the patient is on, which will definitely help in managing our patient in a better manner. So for these patients, apart from the routine pre-anesthetic evaluation, routine questions, there are some additional things which we have to ask, or we have to see related to their, let's say, related to their conditions. So for patients with traumatic brain injury, we need to evaluate the type and severity of injury, traumatic brain injury. Then extracranial injuries. We need to identify associated injuries. Then we need to review all the neuroimaging which the patient may have, the CT, the MRI. So review relevant imaging and lab finding, and also identify if some secondary insult has happened in the patient. So identification of any secondary insult is must, right? So this is related to their injury. Now, patient, as I already said, that evaluation of these patients may be affected by their neurological status. They may not be conscious oriented enough to give us a proper history. Proper anesthetic evaluation may be lacking in these patients. One thing immediately we have to do in acute traumatic brain injury patient is evaluation of the GCS, Glasgow Coma Scale. Now, GCS is something which we practically do in every ICU patient. We evaluate the GCS of the patient to see the central nervous system status. But the GCS was initially defined for evaluating the neurological status of patient with brain injury. So GCS is basically for the use in these patients only. So immediate GCS evaluation should be done, and patients are categorized into severe, intermediate, and mild brain injury according to the GCS score. And GCS, we have three important things to evaluate in this: the best eye response of the patient, the best motor response of the patient, and the best, let's say, the eye response, the motor response, and the best verbal response of the patient, right? On the basis of this, the value 3 varies from 3 to 15. The minimum is 3 and maximum is 15. So, rapid GCS evaluation to identify severity of traumatic brain injury, right? So, as I already said, GCS was initially defined for brain injury only, and we can categorize the traumatic brain injury into mild, moderate, and severe, right? Into mild, moderate, and severe according to the GCS, right? So, as I said, it varies from 3 to 15. The score varies from 3 to 15, and there are three things that we have to see. We have to see the best eye response, we have to see the best motor response, and we have to see the best verbal response. So, what are the things that we see in the GCS? For eye response, we see whether the patient has spontaneous eye opening or not. If the patient has a spontaneous eye opening, the score of 4 is given. If patient opens his eye by, if we call them by verbal command, then we give the score 3. If patient has no eye opening, then patient responds to pain. If we give a pain on the glabella, etc. of the patient, then 2, the score of 2 is given. If patient does not have any eye opening, then we give the score of 1. For verbal response, if patient is oriented and answering our question in a relevant manner, we give a score of 5. If patient is confused but talking to us, the score is 4. If patient is uttering some inappropriate words, then we give the score 3. And if patient is saying in incomprehensible manner, we are not able to understand what exactly the patient is muttering, then it is 2. And no response, no verbal response, then it is 1. For motor response, if patient obeys the command and according to our command do the motor response, so obeys the command, it is 6. If patient is able to localize the pain, if we give a pain stimulus and patient is localizing that, we give score of 5. If patient has let's say a withdrawal response to pain, right, then we give a score of 4. If patient flexes his limb on pain, we give a score of 3. Extension on pain, the limbs, we give score of 2, and no motor response, we give a score of 1. So the score is maximum score is 15, right? 6 plus 4 plus 5, 15. And we categorize into 3 groups according to the GCS score. So if patient has GCS score between 13 to 15, then it is categorized under mild traumatic brain injury, right? If the GCS score is between 9 to 12, then it is categorized under moderate traumatic brain injury. If it is severe, let's say less than 9, then we categorize it under severe traumatic brain injury, right? And according to this categorization, it depends the urgency of the procedure. and post-op care of the patient. Post-operative care, the level of post-op care and prognosis, of course, prognosis of the patient. So GCS evaluation is must in these patients. We have to evaluate the GCS, and accordingly we have to make all our preparation and also prognosticate the relatives if regarding the patient. Now, patient with traumatic brain injury, before we take them even for emergency surgery, we should properly resuscitate them, because intraop there would be a risk of hypotension if the proper resuscitation is not done, and hypotension would affect the cerebral perfusion and cause the secondary insults. So patient should be resuscitated, and should be hemodynamically stable, hemodynamically stable prior to the operative procedure, prior to operative intervention. Now, this is done to minimize intraop hypotension, right? Now, always keep in mind that we have studied that brain has a very good autoregulation from 50 to 150 mm of Hg of mean arterial pressure. But in traumatic brain injury, the cerebral autoregulation is dysregulated. It is disrupted. So, patient is totally pressure dependent, that is blood pressure dependent, to maintain his perfusion pressure. So, we have to maintain the perfusion pressure according to the recommendation, the mean arterial pressure according to the recommendation to maintain the cerebral perfusion pressure. So, we have to remember, so always keep in mind cerebral autoregulation is disrupted and take more time to recover, right? So we need to always keep the blood pressure within the recommended limit. Okay. Now, secondary survey should be done to evaluate for any associated and concealed blood loss. So, proper survey for any associated injury, proper survey for any associated injury, right? And we need to look for even any concealed blood loss happening in these patients, because we have to minimize any risk of intraop hypotension in these patients. Now, after pre-anesthetic checkup, we need to, pre-anesthetic history, etc., we need to evaluate the lab reports of the patient. So, what are the important things that we have to evaluate in the lab reports? We have to get a complete blood count done, complete blood count. We have to get the platelet count, of course, that would be in there, platelet count. I mean, it's important relevance of the platelet. Then PT-INR of the patient done, because number of time the coagulation profile is deranged in these patients. Electrolyte, they may be on osmotherapy and electrolyte imbalance may be there, so we have to get electrolyte done. Glucose, in these patients we have to maintain normoglycemia. Hyper or hypoglycemia can be deleterious. So blood glucose level should be assessed at a regular interval. Now, as I said, that PT-INR is very important because abnormalities of coagulation parameter are common in traumatic brain injury patient. So, ongoing assessment and correction of the any coagulation abnormality should be done in these patients, right? Now, after lab evaluation, the next thing which we need to evaluate is the CT scan and MRI, the neuroimaging evaluation of the patient. Now, CT scan has a very special role, and that gives us a lot of information in acute brain injury patient. It will give us the idea about the lesion, where exactly is the problem. It will tell us the associated increase in intracranial pressure, the cerebral edema, or associated skull fractures, and all this would modulate our anesthetic management. So, neuroimaging, two things are important. CT scan. Now, CT scan, as I said, it is preferred imaging modality, right, in acute phase of traumatic brain injury. Now, it can be done fast, and it will detect the skull, any associated skull fracture. It will detect the intracranial hemorrhage, and cerebral edema in the patient, right? All of them are of significance to us. In a moment I will tell you. Then MRI can also be there. Always MRI will not be there. If it is there, also evaluate the MRI of the patient.